So yes, I'm sure most of you know me, but if you don't, my name's Alex, and I'll be doing all the Opthal stuff today. So if you have any questions, please feel free to message the chat. We are compiling all of the questions, so don't feel silly, just ask away and we will get to all of them sooner or later. This is also the last content lecture before we get to the MCQs as well, so please stick around. We've got really high yield questions as well at the end of this, which is probably going to be the most useful thing with Liv up next. So this is what we'll go through today. And I'll just start off by going through an Opthal history and exam. So if you aren't in the VESPAS group, I would say please do so, because I have done a lecture on this not too long ago. So I'll run through it fairly quickly just for the sake of time. But for an Opthal history, in terms of the main things that you'll probably see in terms of an OSCE, it's probably either eye pain, eye redness, or a painful red eye together, or some sort of visual loss. So whether it's acute or chronic or something, they're the main presenting complaints that you'll see. So really know how to nail these down quite well. And then these are the types of questions that you can use to kind of differentiate what condition it's going to be. So the timeline, whether it's one or both eyes, the pain, redness, etc. And you always want to make sure that if you get a yes to something like, oh, I do have a visual change, you want to make sure that you're questioning that further to make sure you're understanding exactly what's going on. So is it just a bit blurry, or is it the peripheral vision? Is it the central vision? So always double check that stuff. In terms of the Opthal exam, I'll just point to a few key things that you always want to mention. So firstly, always flipping the eyelid, because that's kind of obviously specific to the eye. So make sure you flip the eyelid and look for any foreign bodies, because you can easily miss them. And they can also be really small, so looking quite well. And fluorescein staining. So if anyone's coming with what you think is a foreign body or an ulcer or something like that, it's always good to do fluorescein staining. So that's just describing how to flip the eyelid. I'm not sure if you guys are doing in-person shoots yet, but hopefully if you are, you get a chance to do this, because it's really good practice to do, because once you do it once or a few times, it's quite easy. And these are just some pictures of some staining. So you can see an ulcer. This one here in the top right, you can see an abrasion, so probably from something under the eyelid, and every time you're blinking, it's causing a scratch in the eye. A dendritic ulcer on the bottom left, and then some sort of perforation through the cornea in this bottom right one, but we'll go through all of that. And that's just finishing off. Make sure you do an ophthalmoscopy, but look through this in your own time, because you just need to sit down and practice doing histories and exams with people. So this is just a good list of the differentials that can kind of come up in Opthal, whether it's an OSCE or the written exam. I will touch on pretty much most of these, except for a few that aren't really that useful to know. But this is just a good way of breaking up what condition fits under what differential. So we will start off with a question before we move on. So an 80-year-old woman with no history of eye problems presents with an acutely painful red left eye. Pain radiates to her forehead, she's vomited once, and she has an unresponsive mid-dilated pupil and reduced visual acuity on the left with a cloudy cornea. Let me just get the chat up. Yes, feel free to either send it in the group to everyone or to myself. I'm getting lots of A's, as I should be. So yes, this one's an acute glaucoma. I couldn't have fit any more buzzwords or signs or symptoms if I tried into this one. So let's move on and go through all the things that can cause an acute visual loss. So firstly, going through an acute closed angle glaucoma, a very big condition that pops up time and time again. So know this one really, really well. So the definition, it's when the angle between the iris and the cornea, also called the iridocorneal angle, closes off, and you get a rapid build-up in pressure in the eye. So you can't drain any more fluid. So if you look at the diagram at the bottom, you can see the little angle here between the iris and the cornea. Fluid can flow from the anterior chamber into the front of the eye, and then out. But if for some reason that angle between here, the iris and the cornea closes, all the fluid's going to build up, and that's going to cause a lot of pressure in the eye. That's going to push back on the retinal ganglion cells in the back of the eye and cause death of those cells. And so that can lead to blindness, and which is why it's an emergency. It's roughly accounts for about 5% of all glaucoma as well. So the other 95 being just chronic buildup of pressure in the eye. And risk factors can be just increasing age. It's more common in females. If you've had like a past history or family history of it, or just glaucoma in general. Hyperopia, so that's where you are farsighted, and because of that, you've got a shallower anterior chamber. And so that angle between the iris and cornea is going to be smaller just at your baseline. And if for whatever reason you've had any sort of pupil dilation, so if you've had any anticholinergic agents, so this is why you want to make sure that if you're suspecting ACAG, you don't want to dilate their pupil, which you often do in an ophthalmology exam. So definitely don't dilate the pupil. And darkness as well. So if you're in like a dark movie theater or something like that. In terms of clinical features, which were all kind of mentioned in that question before, so a sudden painful red eye, so very painful, and you can have that kind of temporal headache as well with nausea and vomiting, visual loss. And then other things like halos around lights are quite common, a fixed mid-dilated pupil, so you can see like roughly this type of size pupil, and when you're shining a light in it, it won't change. A hazy cornea as well, you can see this is a little bit hazy, and a hard globe on palpation, so where you actually feel on top of the eye can feel a bit harder than usual. In terms of what we want to do to further investigate, you'd probably just refer them on immediately. You don't really have time to do all of this stuff, but gonioscopy, where you can actually visualize that angle between the iris and cornea, and a slit lamp exam are both things that you can do. But for the most part, it's a medical emergency and you'll refer on. It's not something that you want someone just sitting in your GP clinic for. You'll probably get them to ED. But in the meantime, so supportive things, you can just lie them supine and avoid further dilation. So don't dilate their pupil for the purpose of an exam, and don't put an eye patch on either, because that's going to provide darkness and the pupil's going to dilate. And then just things like pain relief and antiemetics, just for supportive care. And then in terms of medical, we can have a few drops. So Timolol, which is a beta blocker, or pilocarpine, the most common one probably being Timolol, which helps just reduce the pressure in the anterior chamber. And then we've got some IV meds that we'll do when they probably get to ED and are seen by an ophthalmologist. So IV acetazolamide and mannitol. So acetazolamide is a carbonic anhydrase inhibitor, so it helps produce, helps decrease the production of the fluid within the eye, and mannitol to help decrease as well the fluid within that part. And then surgical, we do a laser iridotomy, kind of like punching a hole through that little blockage between the iris and cornea to then allow fluid to flow through. So the next one is a retinal artery occlusion. So this is where you can have a blockage either in the central retinal artery or one of the branches of it. And it doesn't usually resolve. So it's pretty much like a stroke of the eye. And if we think, if it's going to be like a stroke of the eye, well, usually that's going to be caused by something like an embolism from the carotid artery, or things like AF. They're going to be the most common ones. And then like GCA or temporal arteritis, and just all your vascular or metabolic risk factors like diabetes, high blood pressure, cholesterol, etc., all going to be risk factors. The typical story for a retinal artery and even a retinal vein occlusion, which we'll go through next, is an acute onset painless vision loss. So painless vision loss, always be thinking either a retinal artery or a retinal vein occlusion. You might also hear this typical story of a curtain coming down. It's the curtain coming down, it can be for a retinal artery occlusion, a retinal vein occlusion, and also another condition called amaurosis fugax, which again, I'll go through, but it's pretty much the same thing, except it does go away. So again, usually no pain or redness, it's just that painless visual loss. And you can see on examination, if you do your ophthalmoscopy, your pupil dilation, that they will have a rapid afferent pupillary defect. So anything that can affect the optic nerve at the back of the eye can usually cause this RAPD, or Marcus gun pupil, where it doesn't respond appropriately to light. And then probably the most typical thing, which you should be able to just spot immediately, is this typical picture of the fundus, which is a pale retina with a cherry red spot in the middle. And because the macula and all the retinas kind of, if you think of it going like thin and it's kind of dying off, you can see the macula a bit clearer, or like the choroid plexus, which is pigmented behind the macula, because it's kind of all thinning and dying. So in terms of investigations, it's usually clinical diagnosis. Once you see this with your exam, you'll probably refer them immediately. And then afterwards do all your cardio stuff. And then in terms of management, you want to try and urgently dislodge this embolus and restore the blood flow. So urgently referring them, and it's kind of up to the ophthalmologist what they want to do with this, but you want to mainly prevent the other eye from happening as well if it's just in one eye. So you can give things like IV heparin to prevent a clot happening in the other eye. You can try ocular massage, so just rubbing the globe on the top and trying all those things to decrease intraocular pressure, which can potentially dislodge the embolus. But for the most part, there's not too much that may work for this, especially because by the time someone gets to the GP and they get referred to an ophthalmologist, probably a little bit too late. Excuse me. So in terms of a retinal vein occlusion, very similar thing, except it's a thrombosis in the central or branch retinal veins. Same type of risk factors, but the main one for this will be hypertension. And same typical story is that in its acute onset, painless visual loss. In terms of the fundoscopy as well, this is a typical picture that you need to just embed into your mind, because you'll see it all the time with this blood and thunder type appearance that's mentioned, because it looks quite nasty. There's just lots of kind of little hemorrhages everywhere, and it just doesn't look very nice. So anytime you see this, sorry, you will just know vein occlusion. Investigations, again, clinical diagnosis. And for management, you want to do an urgent referral. They're not going to be for antithrombotics as well, because they'll just bleed. And you can do things like laser photocoagulation. So, sorry, I'm just going to grab a drink. Oh, I've got something stuck in my throat and I cannot get it out. Laser photocoagulation. You can also give anti-VEGF injections for the future. So these are injections with a drug that can reduce the production of new blood vessels, and pretty much just lifestyle and risk factor modification. So next one, posterior vitreous detachment. So this is when, if you think this is a good diagram here, you've got your vitreous, which is attached to the retina at the back, and for whatever reason, it comes off. So when you get this separation, it's usually from like age-related or degenerative change. And what it can sometimes lead to is a vitreous hemorrhage, so a bleed in this area, or actual proper retinal detachment. So in terms of clinical features, so the two main ones that occur for this and retinal detachment are flashes and floaters. So this is where you just get, if you imagine this part of the vitreous here is going to then come down and it's going to send off little flashes on the back of the retina. And so you can get flashes and floaters as well. And so what you can do here is actually just remove part of the vitreous if it's refractory with your symptoms, or any kind of hemorrhage as well. And then in terms of retinal detachment, which is a little bit worse, it's when because you've got a few layers, when your inner neurosensory layer separates from the pigmented layer underneath. That's your proper retinal detachment. And there's a few different types, but you don't really need to know them. But in terms of clinical features, it's pretty much the same thing flashes and floaters, and you can get this rapid afferent pupillary defect as well. And so this is a typical thing that you'll see. You can see this is pretty typical of a retinal detachment. So if you just imagine the retina kind of coming down, you're actually going to see that on your fundoscopy. So yeah, investigations, not much you can do, but pretty much do your ophthalmoscopy, and there's a special thing called an ultrasound B scan, but not too common, and I wouldn't really say it either. With management, it's most urgent as well if they've got preserved vision, because if their vision isn't actually affected yet, you can save their vision, but if not, it's a little bit harder. There's lots of different surgeries as well. I wouldn't try and like memorize any of these as well, but just know there's a few different therapies that you can do to kind of put that, or kind of like stick the layers back together. So don't get too worried about that. So this is just a diagram as well. I like using diagrams to help remember things, but these are just the different types of retinal detachment. Haven't seen it pop up ever before, but you might want to remember it. So here's a new question for you all to read through while I go have a coughing fit and come back in about 5 seconds. Ah, excellent, much better. Does anyone have answers for this one? I'm not getting any answers at all. Is this one a bit hard? Got getting a few. There we go. Yes, excellent. Good job, everyone. So everyone that messaged me got that right. Also the people in the group, good job. So this one is temporal arteritis, or giant cell arteritis. So this is a not a super common thing, but it's a very important one to definitely not miss, because again, it's an emergency, as most of these ones are. So it's a vasculitis that can affect your your arteries and lead to blindness. It can involve a few different arteries, but for the most part, it can affect the arteries that supply the eye. In terms of risk factors, age and female sex are the most common ones, but definitely the thing that you need to know is the association with PMR, which I'm sure you're all aware of. So in terms of features, we have painless vision loss. So it's usually, there's a few different ways in that it presents, but it can be ananopia or a horizontal hemianopia. And there was a diagram that I had a little bit earlier on, which goes through what they are. And then the common one being a temporal headache, so just on the side of the head, usually a throbbing type of headache. And you can get quite bad scalp tenderness over the one side of the face as well. Jaw claudication, so painful chewing. And again, a rapid afferent pupillary defect because you're affecting the back of the eye. With investigations, an ESR, so that's absolutely one thing that you want to do. And it's quite often very, very high, so like above 100. And also a biopsy. However, if you've got someone coming in and you think they've got GCA or temporal arteritis, you're not going to go send them off for a biopsy and wait. You'll pretty much just start them on treatment, which is steroids. So you'll put them on high-dose steroids, which they'll be on usually for like 6 months to a year, so a very long time. And whenever you put someone on steroids, especially long-term, you need to think about what that's going to cause, because there's going to be quite a few side effects that come with that. So a PPI, because that can cause gastric ulcers, And also then, because it can affect your bone turnover, you want to protect your bones as well. And definitely want to do an ophthalmo referral as well. Oh, I'm so sorry. So this next question, I'll let you guys read it and then just send your messages through. I've just got a question. Is there a particular steroid that you use for GCA? So from my understanding, and from what I've seen, mostly it's just oral pred. But if it is like a severe emergency case or whatever, or for whatever reason, the ophthalmologist suggests that you can use IV methylpred if it's really urgent and severe. Good, so most of you are putting D, which is absolutely correct. So the next one, optic neuritis. So this is inflammation of the optic nerve, and most commonly associated with MS, again, as I'm sure you've learnt of before, and usually in that kind of younger women category. So when you think of optic neuritis, it can be inflammation of the optic disc. Sorry, the inflammation is relative to the optic disc, so it can either be in front or behind it. And if you think, well, if it's posterior, so behind the optic disc, which we term retrobulbar neuritis, you're not actually going to see anything on ophthalmoscopy. So you can just see a normal optic nerve or optic disc and it doesn't really look that bad. And so that's the most common type as well. So you need to take like the whole clinical picture into account. With your clinical features, so it's usually a visual loss, not so much acute as much as the other ones that we've talked about, but kind of like days to weeks. They can also have color vision loss, and it's usually with red colors, so that's a pretty big giveaway one there. They can have painful eye movements because they've got inflammation, which can affect all of the muscles around the eye. So eye movements can be painful. A central scotoma, which so just that a central part of the eye is kind of like blacked out. And again, a rapid afferent pupillary defect. In terms of the optic disc as well, so again, depends on where it is, but it can either be normal or if it's in front or around the optic disc, it can be swollen. So if you look in this middle picture here in the green column, you can see it's quite swollen there, and that's a bit of a giveaway. When we want to investigate this, you want to do an MRI brain as well, because if you're thinking, well, they've got optic neuritis, it's pretty common as well that they would have MS that may be either diagnosed or undiagnosed, or you'd want to see the progression of it. So doing your MRI brain, and there's this pretty specific test called the Visual Evoked Potential Test, and it pretty much just assesses the speed of your optic nerve. In terms of the management, so again, IV high-dose steroids because you want to reduce that inflammation, and further investigate for MS if you haven't already. This is just an example of the MRI. So here's the left eye. You can see there's inflammation in the optic nerve compared to the right-hand side, and here's one for the right-hand side as well. So the next one, amaurosis fugax. I mentioned this before. I'll skim past this one, but it's pretty much the same as a central retinal artery occlusion, except it's transient. So all the same risk factors, same clinical features. You'll get painless visual loss, but it will come back after like 10, 15 minutes or so. And you'll treat it pretty much the same way with risk factor management. And if you are having this happen again, you are more likely to have a retinal artery occlusion. And I think this is the last one of the acute ones, but endophthalmitis, not super common, not really seen very much, but it is definitely an emergency. So it's a bacterial infection in your aqueous humor, usually within the front of the eye. A few different causes, and when you think of it, it can either be something that's come from outside the eye, so exogenous, whether it's a surgery, injection, or an eye injury, or endogenous, so from like a bacteremia. and it's usually these common organisms. In terms of the clinical features, so this is going to be an acute onset painful visual loss. It's obviously going to be painful. They will definitely have a red eye, and also photophobia, eyelid edema, and then when you look on examination, they'll have a hypopyon. So this is just here. You can see this little bit of pus collection at the bottom of the eye, and also a decreased red reflex because you can also get obscurity. In terms of investigations, you want to do a slit lamp just so you can, sometimes the hypopyon isn't super obvious just with the naked eye, but you can do a slit lamp exam to view very clearly the white blood cells in the anterior chamber. In terms of management, most of these, again, never forget to say you want to do an opthal review, but you can use systemic antibiotics. I wouldn't really commit these to memory. It's not something that comes up very often. But you can also do intravitreal antibiotics, so injecting the antibiotics straight into the eye. And if not, you can do a vitrectomy, so take away a part of the vitreous and just kind of clean away all of that inflamed, infected tissue. So any questions about anything else so far? Just popping up. No. All right, so moving on. So moving on now to gradual visual loss. We've got cataracts, which is the first one. So this is an opacity of the lens, and it can either be acquired or congenital. So acquired, usually in the older population, so usually age-related, diabetes, in certain inflammatory conditions, and drug use with steroids, usually the most common ones, or you can be congenital, so two different kind of groups of people that get cataracts. In terms of where they are, they can be either cortical, so around the edge of the lens, nuclear, which is in the middle, or posterior, subcapsular, so at the back. But again, doesn't really come up that much, so don't worry too much about that. In terms of clinical features, so because you've got an opacification of the lens, your refractive power is reduced, so you're going to have just difficulty with seeing most things like reading, recognizing people, driving, and also going to have trouble with bright lights as well. So a common story is like driving at night with other people having their lights on. You can get quite bad vision then, and you get kind of halos as well around lights. In terms of investigations, so you just want to do your usual risk factor things because like diabetes and hypertension and lipids, they're all risk factors. So test for all of those. Do your slit lamp exam, and also if it's congenital, you want to look for a few different things like urine for any metabolic causes, BSL, serology, karyotype, all of those things. And then in terms of management, again, it's going to be your risk factor modification. So treating the hypertension, the high sugars, you know, can we try and change any of their medications? And then in terms of surgery, you can do a few different things. Again, don't need to know the specifics, but you can just remove the cataract. And if they've got both eyes, you just want to do them several weeks apart, because if you stuff up both of them, well, you stuff up both of their eyes. And then afterwards as well, you can give them topical steroids, tell them to avoid swimming because you don't want any water in the eye, and any strenuous activity as well. Where's that going? So one more question. Just got a few more questions if some of the other 50s want to pop this into that document. So are babies born with cataracts, or do they require surgery as with older patients? And And what is nuclear sclerosis? Just for the sake of time, we'll pop that in the document and we'll answer those afterwards. But for the time being, does anyone have an answer to this question here? I'm getting a good mix between E and B, which is good because they're probably the most common things you'll think about. But for this one's B, and we will go through that right now. So for chronic glaucoma, so mentioned it before, but just an increase in intraocular pressure due to decreased drainage of the fluid. And so because you have increased intraocular pressure, that pushes back at the back of the eye, the retina, and because the peripheral vision has like the least blood supply, that's going to be the part that we lose first. So you lose your peripheral vision and you're going to get tunnel vision. So these are all the common risk factors, so age, family history of glaucoma, diabetes, myopia, thyroid eye disease, lots of different things. So clinical features, loss of peripheral vision progressively is going to be the big one. So you're just going to get worse and worse and worse with your peripheral vision. And it takes a little while to actually notice that that goes away. So you can actually take some time to present with this. And then in terms of signs, disc cupping is going to be a big one. So when you think of cupping, it's the optic cup to disc ratio. And so with the cup in the middle here, it's usually about a third or 0.3 of the size of the entire disc. So when we look at it, if we see that this cup in the middle here starts to grow, we know that there's increased pressure in the eye, pushing back on that cup, and it's increasing that cup to disc ratio. Here's a better photo here. So this is the cup here and the disc on the outside. And you can clearly see that that cup is bigger than normal, as opposed to this picture in the middle here, where the cup is probably less than like that third of the size of the whole disc. So investigations, do your slit lamp, you can do perimetry, but the main one that you can do is tonometry, which is where you just test the pressure of the eye. And in terms of management, you want to screen them regularly to make sure that their vision isn't getting worse, or if it is, that you can do better treatment. But topical things are going to be the most common, so Timolol being the most common treatment. You can also use latanoprost, which is a prostaglandin analog, or these ones here, so oral acetazolamide or laser surgery. This is just a picture as well because it confused the hell out of me last year when you try to think of glaucoma and cupping versus papilledema. So when you think of glaucoma, it's the pressure inside the eye pushing back onto the disc. Whereas papilledema, when you have increased intracranial pressure, as you can see down here, pushing back onto the optic nerve from the outside, and you can kind of get this swelling of the optic disc as a whole. So that's just the difference between kind of cupping and papilledema. Diabetic retinopathy is the other big one. So it's one of the big microvascular complications of diabetes with nephropathy and neuropathy. It comes in 4 stages. So the non-proliferative stage first, and it can go mild, moderate, severe, and then proliferative. So once it's proliferative, it's bad. In terms of risk factors, so we've got increased duration of diabetes, poor control, alongside all of our other typical risk factors. I also have a slide on these things, so don't worry. So with clinical features, so gradually blurred vision as well, and think of your other microvascular and diabetic complications as well, with retinopathy usually being the first one to go. In terms of investigation, so clinical diagnosis and also just looking at the back of the eye and looking for just all of these signs here. In terms of management, we've pretty much done the chronic disease management, so it's that type of thing there. But specifically for proliferative retinopathy, when we have new blood vessels growing, we can do a few things. So laser photocoagulation, which is this here. So when you just use lasers and you kind of get rid of all the peripheral kind of new blood vessels, and you decrease the metabolic demand of the eye. So by decreasing the metabolic demand, you're actually sparing the central vision. So you're kind of just like killing off the peripheral bit of the vision because it's not really doing anything. It's all shitty anyway, just to spare that central part. And if they've had any hemorrhage or bleeding, you can just take that out as well. So this is just going through all the different things that you can see as well. So you've got hard exudates here. Here's your cotton wool spots. You can see microaneurysms, and you wouldn't, I guess you need to look at a few different pictures of these, because just looking at one picture, you're not going to be an expert in picking out like what's a cotton wool spot or what's an exudate. But they're all just a few key things to look for. And this is very clear. You can see all this like new web of blood vessels that have grown, and they grow really poorly and weakly, which is why they can bleed and cause permanent visual loss. So macular degeneration. So I should have included the acute macular degeneration in acute visual loss, but I've decided to do them all together. But anyway, macular degeneration, it's pretty much just degeneration of your macula with no real clear cause. There are a lot of risk factors, which are the typical ones that I've already mentioned, like old age, smoking, history, family history, etc. And so with macular degeneration, you can split up into acute and chronic. Chronic is our dry macular degeneration because we don't have any new growth of any blood vessels, and they're not really prone to bleeding, whereas the wet one is. So with our chronic one, which is most of them, it's characterized by what we would call drusen, which is just these yellow deposits that you can see all over the macula, which is this here. And then with the acute one, this is when you have new blood vessels growing, and this is bad because if these blood vessels then bleed for whatever reason, you can get a permanent visual loss. So you can get gradual visual loss with macular degeneration. You can get this specific thing called metamorphopsia, which is distortion of straight lines, and that's something that we test with the Amsler grid. So you can see the straight lines kind of all become blurry. You get difficulty reading, so it's not something that fixes with a refractive issue, and that's sometimes popped up in a few exam questions where it's said that the person has like tried glasses and gone to their optometrist, or they've just had their optometrist fill a new prescription, but the eyes are still getting worse, and it's usually macular degeneration. But what does help is like a magnifying glass. But this drusen here is pretty much diagnostic of MD. So investigations, look at all their risk factors, do this Amsler grid test, and you can also do this new thing called fluorescein angiography, where you can test for new vessel growth. For management, unfortunately, for macular degeneration, because we don't really know what causes it, it's just a few different risk factor things, that's all we can really do. So it's lifestyle modification and all of that. Can use a magnifier to help them read, and it can also give them an Amsler grid to self-test. And then in terms of wet macular degeneration, you can use these anti-VEGF injections, so straight into the eye. I saw this in a GP clinic once, and the woman said it was just so incredibly painful, and I could not think of anything worse than having injections into my eye. So keep that in mind. So these are some other ones. I'll skip past these, but they don't really come up that often. Read at your own leisure. So any questions? Let me double check. I've got a few here. I'll come back to all of those afterwards. So have a read through this one and let me know what you think. getting a few different answers. So for this one is a corneal ulcer. And I'll quickly go through this one as well. So one of the biggest risk factors for a corneal ulcer is contact lenses being left in, because you can get an infection. And quite a few of you have said bacterial conjunctivitis or photokeratitis, but I'll go through in a sec why that's not. But corneal ulcer, when you see like someone's left a contact lens in, always think an ulcer. So just to go through the anatomy, I might actually skip past this, but here's the anatomy of the front of the eye here, like the cornea and the sclera. And so let's start off with the corneal abrasion. So this is just kind of a defect in the outer layer of the cornea. So it can happen for a few different things. Usually a foreign body or a contact lens can be a little bit irritating sometimes, or if you've just scratched your eye. Usually clears though within 48 hours because it is just a superficial injury. Usually get a painful red eye, can also be quite watery and teary, can have photophobia, and it can also feel like there's a foreign body in there, even though there's actually not. But the key thing is, because it's not going through like the pupil and a full penetrating injury, you don't have a visual defect and you don't have any pupil deformity. So investigations, a slit lamp exam again, and definitely doing your fluorescein dye, which will help pick it up. And a key thing with this one and a lot of other injuries is that they need daily review. So this has popped up in quite a few exam questions where you've had someone with like something go in their eye and they need to have a review. You need to make sure that you're doing reviews every single day until they're properly healed. And then in terms of management, so using topical antibiotics, which is chloramphenicol. It's like the main one that pops up in Opthal. Analgesia, using an eye patch as well. And if you have some sort of injury and you've got contact lenses, just don't use them for the time being. And topical lubrication as well, just to help with reducing like dry eyes, which can just increase pain and redness. With corneal ulcer, so this is just a bit worse. So it's a deeper corneal epithelial defect, and it's usually from an infection as well. So unlike abrasions, they don't just develop quickly and go away in a few days. They usually develop over a few days and last a bit longer as well. There's also this specific type called a Morons Ulcer, which is from an autoimmune disease, but just know that that exists. A few different risk factors, so corneal contact lenses, as I said. If you have pre-existing corneal abrasions, any surgery or any exposed cornea as well. So if you think with Bell's palsy, if one side of your face is paralyzed, you can't actually blink properly, so it's exposed. And an ectropion as well, where your eyelid kind of hangs down and exposes your eye. So these are the typical symptoms. Again, painful red eye, lacrimation, photophobia, all of the same things. And a key thing that will be a differentiator on investigation is if you do a slit lamp exam with your fluorescein staining, you can see a positive Sidel test. So this is where, because you've got a penetration through the eye, you've got aqueous humor that leaks out into the front of the eye, and that's going to dilute your fluorescein stain. So with any dilution of that stain, that's going to be a positive test, and you know that there's going to be an ulcer that's gone through the eye. Also, if you think it's bacterial or infective, you can do a scraping. In terms of management, definitely need to do an ophthal referral. You can use topical antibiotics. Depends on what the cause is really, but ophthal can guide that, and pain relief. And one key thing as well that you can do, which is very ophthal specific, is use atropine, which is a cycloplegic, and it pretty much just helps reduce the spasm in your ciliary muscle. So this should be a spot diagnosis. So feel free to say in your message as well what this is, and then what the answer would be. Very good. Most of you have got that. So most of you have said it's Hsv keratitis. So yep, anytime you see this dendritic ulcer, it's Hsv keratitis, and we use an antiviral agent, so B. So with microbial keratitis, so viral, bacterial, and amoebic are the three different groups, but it's usually going to be viral. And when we think of viral, the two main ones are Hsv and VZV. So risk factors, again, pretty much the same as all the other ones. So contact lenses, abrasions, blah, blah, blah. Clinical features as well, again, same type of thing, painful red eye, lacrimation, photophobia, but a few key differentiating things. So with Hsv, we can see vesicles because we know that Hsv can cause vesicles. The dendritic ulcer is absolutely the big thing that we can see. So anytime you see that picture, you should know what it is. And then for VZV as well, so you can see Hutchinson's sign, which is where you get vesicles on the tip of your nose, because the virus, we know it infects the first or the ophthalmic portion of our trigeminal nerve, which kind of is that top part of the face. So if we see that they've got issues with their eye and vesicles on the tip of their nose, we know it's going to be pretty much shingles. And if it's bacterial, you might see a hypopyon, so a collection in the anterior chamber. And these are all the investigations, again, same that we've done before. In terms of management, so if it's Hsv and VZV, they're a little bit different, but Hsv, acyclovir for 14 days. And we don't want to use steroids in any of these as well, because that will just make things worse. In terms of VZV, you can use a different antiviral called famciclovir, and you just want to make sure that you're excluding other causes of a red eye as well. You can also do debridement with your ophthalmoreferral. So this is usually only if you can see the dendritic ulcer, where you kind of just like try and clean things up a bit. And with bacterial as well, you can use specific antibiotics. And the two that you pretty much always use are either chloramphenicol or ciprofloxacin. So with chemical burns being the next one, I'll kind of skip past this one. But these are some important questions that you want to ask in terms of a burn. And in terms of the management, you just want to make sure that you're setting it all up properly, because you want to do an ophthalmoreferral firstly, and then make sure that you're removing the chemical, removing a contact lens, and testing the pH as well, because you want to know if it's acidic or alkaline. And just try and clean out the area. And I think the main thing to know is that you want to do irrigation. So using an eye bath for at least 30 minutes to an hour. And then the rest, have a quick read through that. It doesn't really come up that often. In terms of a foreign body, a few different things that can cause a foreign body. So sometimes an eyelash, which I'll go through in a little bit. Metal, so this is usually from metal grinders that people that don't wear PPE. A high-speed mechanism is usually concerning, so you want to know if it's happened high speed, because that can be quite traumatic. And literally anything else can cause a foreign body. So you can have this acutely painful red eye again, and just that kind of gritty, irritating feeling. You can get visual changes, that kind of scleral injection where all of the blood vessels look really red and angry. And this key one being a pupil defect. So if you've got something that's gone through and affected the pupil will usually point towards where the defect is. So this picture down here, you can see there's a foreign body with a little rust ring around it, and you can see that the pupil is pointing down. So there's a pupillary defect, and it usually points to where it is. So again, investigations, same things. And this, you want to do your ophthalmoreferral, make sure you've got an eye shield on, so popping a patch on. Pain relief, because that's going to be important. And when you're removing a foreign body and a rust ring as well, you first want to try with just a cotton bud to see if you can kind of sweep or flick it off. If not, what you usually do is get a 25 gauge needle and make sure that the bevel is up, so you don't stick the needle through their eye. But you just need to gently go very parallel to the eye and try and just pick the little foreign body up, whatever it is. This sounds really awful and scary, but it's actually quite easy. I've seen it done a few times. Haven't done it myself, but it seems quite easy when you actually see it done. Also give them antibiotics and definitely review them in at least a day. These are some other ones you can go through in your own time. Might be like an MCQ or something on one of these, but not too important. So almost at the end, read through this one. Let me know what you think. Yes, very good. So pretty much everyone has said E. So very good. So typical story of viral conjunctivitis starting in one eye and then spreading to the other one, becoming very red and watery. So yes, and it's usually in a kid. Other kids have it as well. And just one more question here. I do have to finish up soon, so I will kind of race through the end. I might actually just explain this one for the sake of time. But this one is a allergic conjunctivitis. So this looks actually really awful, but it's just swelling of the conjunctiva from like an associated hay fever or something. And the thing that we use is this drop here, which I'll go through. So for conjunctivitis, it's viral, bacterial, and allergic are the main types. So viral, it's usually these viruses, highly contagious. It's usually unilateral, spreads to both eyes, and usually just get a watery eye, not usually discharging with like any sort of pus. And you usually get lymphadenopathy as well around the ears. You mainly do supportive treatment, and you want to just make sure you reduce the spread, so good hygiene, and make sure that you're cleaning out the eyes with like good eye washes and cool compresses and pain relief. With bacterial, most common is like your strep pneumonia or pyogenes, but you can also have either gonococcal or chlamydial. Gonococcal is severe, you need to make sure you're referring, and chlamydial usually common in a neonate. So with this one, you usually have like a very purulent discharge, and you get lots of eyelashes sticking together, and it's usually a bit more acute and more severe as well, and you need to use antibiotics. With allergic, it's usually have very glassy, itchy, red, annoying eyes. It's usually both of them as well. And I think they probably have asthma, eczema, hay fever. You can use topical antihistamine, so olopatadine is a common one, or ketotifen. And you can sometimes use a vasoconstrictor or steroids, absolutely under opthal guidance. Sorry, I should also just go through with just the clinical features. Red eyes, it can be quite gritty and irritating, some sort of discharge, and usually no visual loss are pretty much common to all of them. And it's good to just clarify as well with the visual loss, because you get quite watery, dischargey eyes that can affect your vision, but if you clear away with blinking, the vision should come back. That's just some pictures. And I'm just going to quickly race through episcleritis and scleritis. So inflammation of just either the episclera or the sclera. Episcleritis generally is better than scleritis, so because it's more superficial, it's usually not as bad, whereas scleritis, inflammation of the actual sclera, the white part of the eye, is usually quite a bit worse, and they're usually associated with autoimmune conditions as well. But I will maybe just let you read through this just for the sake of time so we can get to the MCQs. And this is iritis again. I will just let you read through this one. And I think the last thing that I'll go through are these here before we move on. So with eyelid stuff, the two main things that you'll see, or the three main things, are a hordeolum, a chalazion, and blepharitis. So for a hordeolum, this is usually our sty. There's a few different types depending on where the inflammation is, but for the most common one, it's an external sty. which is like this one here. And the main thing to differentiate between hordeolum and chalazion is that a hordeolum hurts. So just remember H, hordeolum hurts. So these ones are tender, and you just need to do your conservative treatment for them all. It's like warm compresses, steaming, massage, and you can sometimes use oral antibiotics if they're not getting any better for the internal ones, and topical antibiotics for your external ones. In terms of a chalazion, so it's not actually an infection, just more so chronic granuloma occurring in the meibomian glands. And so they don't have those typical signs of inflammation like pain, red, swollen heat. It's just like long-standing growth. So it's not usually painful, but you do have a swelling and like a lump that's quite obvious, and it's quite rubbery as well, and pretty much the same kind of conservative management, but you can also cut them out if they're annoying. And then the last one being blepharitis, which is kind of just chronic inflammation of the whole eyelid, and it's usually associated with seborrheic dermatitis, so which you may have heard Kat go through with derm. So you can see quite a crusty eyelid as well, and it can be quite itchy and gritty and just really annoying. So one of the main things that you do with conservative management is getting a cotton wool and baby shampoo. It's a bit weird, but you can that's how you can clean the eyelid out and help it. The unfortunate thing is that this usually recurs and it doesn't usually go away, and it's hard to actually get rid of. So making sure that people keep on top of that management is important. And you can then sometimes use antibiotics and steroids. And these are just some other ones, and these are some good pictures of like an entropion, an ectropion, a trichiasis, BCCs, and also the taping that we do. And I'll just skip past all of this. And that is the end. Sorry, I had to rush through the end of that. But that's the end. If there's any other questions, we've been monitoring the chat, and people would have been popping these in a document that we have, and we'll have those all answered. So don't worry if I haven't answered your question yet.